So our next speaker is Dr. Elizabeth Stephenson. Dr. Stephenson went to Columbia for medical school. She did her residency fellowship and EP fellowship at Boston Children's. And she currently serves as a professor of pediatrics at University of Toronto and Toronto Sick Kids. And she's an expert on implantable cardiac devices and has authored many of the key papers on this in children and young adults. So I'd like to introduce Dr. Elizabeth Stephenson.
Thank you so much. I'm going to presume that everyone can see my slides and hear me, and just yell at me if I'm doing the classic not unmuted or something like that. And I'll try to speed through a big topic in a short amount of time. These are my disclosures. So first of all, when we want to think about ICDs in general, you want to sort of decide what exactly are you putting it in for. And ideally, you'd like to decrease mortality, but also minimize the morbidity. And we know that there's significant morbidity associated with these devices. In order to do that, there are two things that you need to do. The first is correctly identify those at risk of lethal arrhythmia, and we've been hearing about that in some of the other talks today. And what I'm going to focus on is the second one, which is choosing the best programming and hardware for your individual patient. So the subcutaneous ICD, just in case not everyone is familiar with it, is an ICD that sits outside of the thorax as compared to the transvenous ICD, where the generator sits in the axilla and the lead is tunneled across and up alongside the sternum. So there are advantages, and of course there are disadvantages to this type of system, and we're going to explore those a little bit. To begin with, all of these are really centered around the fact that there's no intravascular lead. So that gives protection against the biggest downside of the transvenous ICDs, which are the potentially devastating effects of an infection, which can lead to endocarditis and even death. However, it also leads to the major disadvantages of the device, which are that sensing can be compromised with both undersensing and oversensing, and that more energy is required to defibrillate when all of your voltage is traveling outside of the chest. That means you need a larger generator and you have a shorter battery longevity. This is what the device can look like in our smallest patients. And you can see that there's a tremendous amount of tension on the skin here. This is the first generation device, which is a bit bigger than the current generation, seen in a 32 kilogram child. Here's an example of some of the oversensing that's very frequently seen, unfortunately, and you can see here that into this patient's sinus rhythm, you have frequent T-wave oversensing, ultimately leading to charging from the diagnosis of tachycardia and an inappropriate shock. Similarly, from the same paper, you see very concerning undersensing that can be seen. And this is an episode of VF that actually started about 2 seconds prior to this training, to this tracing. And you can see that there is lots of undersensing when the VF is more of a fine VF. The device does detect and start to charge here, but then again, it starts to undersense, and you have inappropriate markers missing the tachycardia, leading to a delay in shock. Thank goodness this patient eventually did get a shock, but it was quite delivered. So one of the things that we can do to help with this is to screen patients appropriately. And you can see here the screening tool that's used, and there are 3 different vectors: primary, secondary, and alternate. And you want to make sure that while you're screening, that your QRS and T-wave are fitting into the screening tool. It's also important to consider a post-exercise screen, particularly in our younger patients and those who we know can have very dynamic repolarization changes with exercise. So let's talk a little bit about the longevity. So on the left here, you see device longevity of the sub-Q ICD, and these are for device replacements purely for battery-based reasons. And there's censoring of any devices that were explanted for other reasons. This paper is a little bit more recent, 2019, looking at transvenous ICDs, but it actually looks back over the same time period. And you can see that, not surprisingly, those that pace more, the CRT devices, have the lowest battery life, followed by the dual chamber, and then the single chamber devices. And the comparison is with the sub-Q, an average of 5 years, compared to transvenous average of 7 years. And over the lifetime in our young patients, this adds up to quite a few generator changes, with the sub-Q requiring an average of 13, as opposed to the transvenous, which was 9. So that's a lot of extra surgeries you need to think about. Obviously, the sub-Q ICD is relatively new and is still improving, and we are seeing improvement in the generators. There was a great meta-analysis that looked at all of the small early sub-Q ICD studies that came out in 2018. And not surprisingly, they found that the lead complications were significantly lower in the sub-Q ICD population. However, interestingly, infectious complications were significantly higher in the transvenous ICD. And this probably has to do with a higher rate of dehiscence and erosion that are seen with the very large generator. And overall, for all-cause complications, there was no significant difference in these populations. I don't know if you guys can see my notifications, but I'm getting COVID notifications from my child's school as we talk. So we'll look at that when we're done. What a life. Okay, so we have great new evidence, which is really helpful. The Praetorian trials just released a few months ago, and this was quite a large non-blinded RCT, looking at just over 400 sub-Q and just over 400 transvenous ICDs. It is industry funded and was published in New England Journal. So what they found was, not surprisingly, that in the transvenous ICDs, there was a higher risk of device-related complications, and that there was a lower risk in transvenous of inappropriate shocks. There was hope that with the newest generation of sub-Q ICDs, which have, they thought, better detection and better algorithm and better screening, that they would begin to approximate the transvenous ICD rates, but they actually still have a higher inappropriate shock rate. And when they looked at their primary composite endpoint, this was a non-inferiority trial, I should say, they did find that the subcutaneous ICD was in fact non-inferior to the transvenous ICD. And I think this reminds us that what we really need to be doing here is deciding which device is right for the individual patient in front of you. One of the things to think about is how large your patient is. So Pisano et al. In 2017 looked at their center experience. They had 12 patients who were between the ages of 15 and 29. And you can see there were 3 ARVC, 3 HCM, 5 with congenital heart disease, and 1 long QT patient. And of that group, 4 of them experienced device complications that required surgical intervention. And they were all around infection and erosion. And all 4 of those were quite small, with a BMI of less than 20. So that may be something that we should be looking for as a risk factor for people that are more likely to have device complications. Similarly, in the same year, Bettine et al. Looked at their sub-Q ICDs, and this is a nice paper for young people. They compared transvenous and sub-Q in an age-matched fashion. This graph is just looking at their sub-Q population, and what they found was that in these 31 patients, the inappropriate shocks were much, much more frequent in the younger patients. And we know this from our transvenous experience as well, that we see a higher rate of inappropriate shocks. But this is really quite impressive. And important to note that, like a lot of the sub-Q ICD papers, these are, the majority of these are inherited arrhythmia patients included. So this really is relevant to the group of patients that we're talking about now. So why do we care about these inappropriate shocks? Well, all shocks are bad. We know this, and we've known this for a while. In Scud heft, we saw that in a heart failure population, inappropriate shocks as well as appropriate shocks carried a mortality risk. The appropriate shocks, not so surprising, hazard ratio of 5.7. And with that, this is a sicker group of patients, and so that's not very surprising. But interestingly, even the inappropriate shocks had a hazard ratio of almost 2. So this is not just an unpleasant event, but it has life implications. Similarly, the populations that we're talking about often have catecholamine-driven arrhythmias. And so they are at particularly high risk from inappropriate shocks, including potentially fatal electric storms in the CPVT population. Now, we've learned over the years that we really should try to avoid putting ICDs of any type into a CPVT patient, but sometimes you may not feel you have a choice. In that case, avoiding inappropriate shocks is absolutely essential. So that's one population to be very careful of. What else do we know about this specific population? Well, Conte et al. Looked at their large Brugada syndrome group and compared it to some of their other channelopathies. So they had a slightly older group, 100 patients, 75% male, with a mean age of 46. 60% of their population was Brugada, and they compared against 20% LQT and 20% other inherited arrhythmias. They showed that they had a 13% screen failure overall, which is pretty similar to what's seen in the general sub-Q population, but it increased in the Brugada group to 18% and increased even more with Adrenaline. What they saw was that patients that passed the initial screen would then fail when they had those dynamic changes that we know Brugada patients can have either with Adrenaline or just at baseline with changes in both their QRS and their T-wave. So that's something to be quite careful of. What else do we know? Well, Rudick et al. Around the same time reviewed their own sub-Q ICD experience. And in this group, they had 40% Brugada, 27% IVF, 10 long QT, and 23 other. And they showed 20% appropriate shocks in 10 patients and 4 appropriate shocks in 2 patients, with relatively similar to transvenous rates. So overall, we can see that the subcutaneous ICD has matured to a point that it is non-inferior to the transvenous ICD, although anybody on the Heart Rhythm website would have seen that there is a new advisory for the subcutaneous ICD that just came out today. So we are still on the learning curve. You have to determine which device you need for your individual patient and consider your patient size. You need to screen them, including post-exercise. You need to think about the risk of post-shock bradycardia, which we didn't really talk about, but you cannot pace these patients, and whether or not they would benefit from ATP. Anyone who would benefit from ATP has a clear argument for a transvenous ICD. You need to think about the risk of inappropriate shocks in that particular patient. Thank you so much.
Okay, great. Thank you, Beth. We have a couple of questions. The first is getting an ICD effective? My dad was just diagnosed with Brugada syndrome tonight, looking for answers to give him when I visit tomorrow.
It's a great question. I'm afraid I can't answer for your father because every case really does need to be considered individually, and so we would need to know a lot more about his condition. But typically, the rules around Brugada syndrome are that if someone appears to be extremely high risk, to have had a cardiac arrest or other very, very concerning event, it's often something that we would be discussing. They are very effective at treating malignant arrhythmias. So if you need one, they are a very effective device.
Okay, good, thank you. And then the second question is, what would you consider the smallest patient size where an S-ICD would be an appropriate choice?
Oh, that's a really tough one. I have to admit my own personal bias. I don't put in sub-Q ICDs, so I'm not the best person to answer this. But I have been impressed with the some of the skin erosions that have been seen and pocket problems in the smaller patients. So I think we do need to be quite careful. And absolutely, if you're putting it into a smaller patient, you need to be putting it in an inframuscular position in order to protect the skin a bit more. But I don't have an actual number that I would want to put to that. And I do think you have to look at the body habitus of the individual patient. A very, very thin patient is probably at higher risk of erosion and pocket complications.
Okay, great. Well, thank you very much. And I think we'll keep moving forward.
Thanks so much, everyone.